enjoy doing them. I hope you will too. As David mentioned, today's topic is how to audit-proof your practice in 5 steps. These are the 5 steps that I feel are vital to figure out and make sure you're doing properly. So you should see them on your screen. Step 1, patient forms. Step 2, treatment plan. Step 3, SOAP notes. Step 4, CPT and diagnosis code linking and pointing. And step 5, cash plans and financial needs. So let's begin with step 1, patient forms. So brand new patient walks into your practice. I recommend you give the patient a very good quality health history intake form. When I say good quality, it has to ask certain questions that will save you time in the long run and will be able to help you justify some of the codes that you bill just by having the patient fill out certain forms. So get a good quality health history form. You can get them online. Companies like Colwell, Medical Arts Press, Parker Systems, Backtalk Systems. Get in touch with a good quality company. Get forms that look nice. You know, some of them have beautiful, colorful spines on them. You know, get good quality forms. I hope you're not using forms that are copies of copies of copies that you are using from the chiropractor you bought the practice from who started using 20 years ago. You know, I see some offices, you know, that the office is beautiful, but the forms are just so old and outdated. It doesn't give the patient a good first impression. You want to give the patient a very good, you want to roll out the red carpet for this patient. Remember, when a brand new patient walks into your office, they don't see you, the doctor, first. First of all, they're speaking to one of your staff members on the phone before they even come in. So you want to make sure that your staff gives a very good high-quality impression of your practice. And then when the patient comes in, they open up the door. It should be a nice, clean office, smells nice, nice carpet, nice painting, professional staff. So now you hand them a form. You want to make sure the form is professional. Now you may have certain forms for certain types of patients, like your patients that are in car accidents. You should have a separate form because it's going to ask specific questions relating to the accident. You may have one for your workers' comp patients. For your general patients, have a good quality health history form for your regular insurance patients and your cash patients. Next, HIPAA forms. I don't care if you're a solo practice provider seeing one cash patient. You still need to follow all the HIPAA rules and guidelines. I know some providers, they try and get out of it. Let's just move past that. Have a notice of privacy practices. This is a form that the patient has to review and sign, that they understand that you're going to keep their personal, private health information private. Next, some financial information like authorization of payments to you, right? You want the checks coming to you, assuming that that's the case. You know, unless you're a cash practice or a cash patient and you want the patient to pay you and then you want to go to the patient, then fine. You don't have to have them sign a form that authorizes payments be sent to you. Authorization to release information. An auto-deduct form. Maybe you have patients paying you a certain amount every month. Just have it set up where you can charge their card every month, if that's illegal in your state, or you can automatically deduct the amount from their checking account right into your checking account. I love that, right? Don't you love that? A terms of acceptance form. There are certain malpractice insurance companies that require your patients fill out a terms of acceptance form. I recommend you have an office policy form that just gives the general rules of your practice. Something as simple as when you come in, Mrs. Jones, you need to sign in. You need to let us know if you're not going to make an appointment. You need to notify us if you have a new. You know, there's a whole bunch of information that you should have on this general office policy form. How about outcome assessment form? Strongly recommend you have the patient fill out an outcome assessment form. If you know the patient's condition in advance, give them an outcome measurement form related to their condition. So, for example, if you know they have a neck problem, give them the neck disability index form. Lower back problem, give them the Oswestry or the Roland Morris. Upper extremity problem, give them the DASH form. DASH stands for disability of the arm, shoulder, and hand. Lower extremity problem, give them the lower extremity functional scale questionnaire. And any other forms specific to your practice that I may not have mentioned. Also, brand new patient comes into the office, make a copy, insurance card front and back, and get a photo ID. This policy form that I was mentioning just a couple of minutes ago. So when you sign in, Mrs. Jones, when you arrive, sign in. You have a new injury, appointments. We do healthcare classes. I know this seems to be a lost art in the chiropractic profession. Many years ago, most chiropractors did healthcare classes every week or every month. Doesn't seem that common as much as it used to. But if you still do them, put it in your policy that you strongly recommend that every patient attend your healthcare class. Payment of bills. I recommend you have a separate, I recommend you have a separate form. If you want to add it to your general office policy financial information, go right ahead, but I typically have a separate form, which I'm going to talk about later as far as financial obligations, patient financial obligations, separate form, but you could put it on your general office policy form. Rescheduling appointments, progress evaluations. Tell patients that every 6 to 12 visits they're going to get reevaluated, and there's a charge for it. You know, it's funny, you learn from your mistakes, right? Some of my biggest successes have come from my biggest mistakes. I remember one patient, I did a re-exam, I charged her. She came in with the EOB saying, "Hey, Dr. Kotlar, what's this charge for $45? I said, "You remember a couple of weeks ago you came in and I did a re-exam?" She said, "Yeah, I remember you did the re-exam, but you didn't tell me there was going to be a charge for it." She got upset. So we want to prevent unnecessary upsets, right? It all comes down to communication. Tell patients they're going to get reevaluated every 6 to 12 visits, maybe sooner. I don't know. That's up to you and your practice. And tell them there's going to be a charge in advance so they can't get upset. So there's a sample policy. Let's go to step 2, which is creating a treatment plan. Ultra important. Come on, every new patient, I don't care if it's a cash patient, work comp, personal injury, Blue Cross Blue Shield, in-network, out-of-network, doesn't matter. You have to create a care plan for every single new patient that walks into your office. So let's talk about it a little bit. Creating a chiropractic care plan begins with the patient's first visit. So what does a care plan consist of? In my opinion, 6 items: history, exam, diagnosis, goals, services to be rendered, and the schedule of care. I look at the care plan as the foundation. You see the photo of a foundation of a house. You don't build the kitchen first when you're building a house. You build the foundation. The care plan, the treatment plan, the plan for care, I don't care what you call it, sets the foundation. Give you the opportunity to set the table for the rest of care. So let's talk a little bit about the history. Okay, so we have the history. There's 4 levels: problem-focused, expanded problem-focused, detailed, and comprehensive. 99203 is the most commonly billed new patient CPT code, so let's talk about it a little bit. 99203 requires that you write down, either in your software, you generate it out of your documentation software, or if you're using forms and you're filling out forms, it has to contain at least 1 chief complaint, 4 HPIs, that's the history of present illness, similar to the OPQRST, Learning Chiropractic College. Review of systems, you have to review 2 to 9 systems in order to justify 99203. And you have to go through at least 1 past history or a family history or a social history. So a chief complaint is what? Chief complaint is a concise statement describing the symptom, the condition. The HPI, or in chiropractic college you may have been taught this as the OPQRST. That's the onset, what makes it worse, what makes it better, the quality of the pain. Is it sharp, burning, dull, intermittent, radiating? Is it, the severity? Get a pain scale. How long has it been going on? Any changes since the last visit? duration? Is it intermittent? Is it constant? Is it worse with exercise? Is it better with rest? Is it improving over the last few weeks? What does the condition prevent the patient from doing? Associated signs and symptoms like numbness, tingling, swelling. Has the patient seen a chiropractor in the past? Those are some of the most important questions to ask during the HPI. Next, you need to do a system review. Here's a little chart. Maybe I should, share this with you here as each one. So chief complaint we went through, the HPI we went through, you need 4 of those. As far as the review of system, you have to review 2 to 9. There are a bunch of systems in the body: eyes, ears, nose, throat, cardiovascular, respiratory, GI, GU, skin, neurological, psychiatric, endocrine, hematologic, lymphatic, allergic, immunologic, musculoskeletal. A whole bunch of systems in the body you have to review 2 to 9 for 99203. And then you have to review at least one item from the PFSH column. See it on your screen, the last column on the right. Any previous spine-related problems is a past history example. Family history, maybe the patient's mother or father had osteoarthritis, osteoporosis. Social history, stress on the job. Is the patient a smoker? Alcohol, exercise. So those are these certain key points you have to meet as far as the history goes. Then we have the exam. The exam also has 4 levels here. If you're billing 99203, you have to examine 12 portions or 12 bullet points. You need 12 exam findings. Most of the doctors I work with are not, well, when they first become a member of Target Coding, they're not getting 12 exam findings. They're lucky they're getting paid. The ones that get asked for their notes are not getting paid because most doctors are not justifying 12 exam findings. So make sure you are justifying your 12 findings. See, for 99201, you need 1 to 5 findings. For 99202, you need 6. For 99203, you need 12 exam findings. 99204 and 99205, it's a whole different ballgame. You have to perform all elements identified by a bullet. That's within the E&M guidelines. The E&M guidelines are what all the insurance companies use to determine whether or not to pay you. So you should get for E&M guidelines. Those of you listening to this presentation, if you're interested in getting the E&M guidelines, send an email to amy@targetcoding.com, amy@targetcoding.com. That's amy@targetcoding.com, and she'll send you the E&M guidelines so you can see these bullet points that I'm referring to. So how do you get bullet points? If you palpate the lower back and you find tenderness, there's a bullet point. You find subluxations in the neck, there's another bullet point. You do range of motion in the neck, there's another bullet point. You check reflexes, check the skin. This is all part of the musculoskeletal exam. Writing down the general appearance of the patient counts as a bullet point. Vital signs, if you do 3 vital signs, that counts as a bullet point. I'm telling you, most of the doctors that I evaluate their new patient documentation, they are not meeting the 12 bullet points. So please make sure you start doing that. After the exam and the history, then you have to go through some decision making to come up with a diagnosis. According to CMS, the definition of medical necessity includes the items or services being provided must be reasonable and necessary for the diagnosis. So your diagnosis must also link to the procedures that you're doing. It's not enough to pick a diagnosis just because it seems right. Your diagnosis should have validity, should be substantiated by your documentation. The clinical rationale for choosing a diagnosis must be in writing and entered into the notes. Your diagnosis must be accurate, especially when you're reporting certain rehab procedures. For example, if you're going to do myofascial shoulder, let's say, for shoulder stiffness, the diagnosis is 719.51, that's shoulder stiffness. That would match or link with myofascial release, which is 97140. Now, ICD-9 codes are comprised of 3, 4, and 5 digits. ICD-10, different story. That's 5, 6, and 7 digits. ICD-10 is coming around on October 1st, 2014. So be aware of that. I don't like when providers diagnose a working diagnosis or a probable diagnosis. My feeling is wait a few visits to submit a claim that has a definitive diagnosis than submitting one that might not be correct. Next, the goals. You need to have goals for the patient. I know years ago, for you, those of you in practice for, I don't know, more than 10, 15 years, we didn't really set goals back then. Nowadays, you must. Especially if you're going to be seeing the patient more than 6 to 12 visits, you have to create goals and meet the goals. If you don't meet the goals, you have to discharge the patient because whatever you're doing isn't working, right? So you have to set clinical goals. You could start with the patient's intake form. You could get baseline numbers in the consultation, baseline numbers in the exam. Update the goals as the patient is improving. Set goals that are feasible and include a time frame. For example, range of motion. Patient comes in, first visit, lumbar flexion is what? 90 degrees? That's normal, right? Patient, first visit, it's only 40 degrees with severe pain. Patient can't bend more than 40 degrees. So what's your goal? How about the long-term goal is 85 degrees. Maybe they'll never get to 90. But your short-term goal is to get them to 65 degrees with less pain. So that's how you set goals. Also, as I mentioned earlier, use outcome measurements. More important now than ever before. You can use it on your first visit to set baseline numbers. I gave you the forms that I feel are the gold standard in the industry. Score them, mark them. Hey, give them to the patient more often than once every month. Set goals. For example, we want to reduce low back pain from 9 to 6. So using pain scales as a goal. Want to increase lumbar flexion from 40 to 65 degrees. You're using range of motion there as a goal. And an ADL is very important. We want to increase the patient's ability to sit at a computer without low back pain and stiffness from 10 minutes to 20 minutes within 4 weeks. Want to get the patient to be able to walk long distances without pain. Get the patient to be able to get in and out of bed without assistance. You know, there's a whole bunch of goals that are out there that you should start using. Members of we give you a whole list of them, and you could just check them off as the patient improves. Next part of the treatment plan, you're going to recommend certain services. What are you going to recommend? It's a whole bunch of things you could recommend. Ice, heat, traction, stim, manual therapy, massage therapy, adjustments, therapeutic exercises, neuromuscular reeducation, therapeutic activities, DME, x-rays, diagnostic testing. Going to refer the patient out for consultations, strapping, kinesiotaping, casting, orthotics, functional evaluations, trigger point therapy. As chiropractors, you cannot do injections, but if you are a multi-specialty practice, yes, trigger point therapy, lab work, weight loss programs, nutritional consultations. This is the menu that you should have in your practice. Now, for those of you that are not doing all of these, that's fine. If you're happy with the way things are going in your practice, you don't want to add anything, fine. But if you feel like reimbursement, you want to try and figure out a way to make more money, then maybe there's a few things here on this menu that now you want to add and start doing. These are all excellent things. In my multi-specialty practice, we did all these things. I did everything you see on your screen, plus more. We did chelation therapy and intravenous vitamin and mineral therapy and cellulite reduction, you know, along with all of the things you see on your screen. So start getting creative. Start thinking of things that you can do to add to your practice if you think that you want to. Also, when it comes to some of these therapeutic procedure codes like therapeutic exercises, neuromuscular reeducation, therapeutic activities, these are time-based codes. Check all the carriers that you bill to make sure you are complying with their rules and guidelines on the time-based codes. For example, according to CMS, one unit is 8 to 22 minutes, but you need to be careful because if, let's say you do 10 minutes of myofascial release and 10 minutes of therapeutic exercises, that totals 20 minutes. You cannot bill 2 units. You can only bill 1 because 20 minutes falls in between 8 and 22. So be careful of that. A lot of doctors are not billing time codes properly. Next, the schedule of care. This is pretty straightforward. This is probably the easiest one out of all of them. Schedule of care must include the frequency and duration. In this example, the patient's going to be seen 3 times per week. That's the frequency. For how long? The duration, 4 weeks. Then we're going to reevaluate. So that's the care plan. Step number 3, SOAP note documentation. Just going to throw a few things out here. Never alter your records. Malpractice attorneys can hire expert document examiners to analyze chart notes when it appears a record may have been changed. So you cannot alter, change, delete, erase, add anything to your SOAP notes once they've been entered into the record. Next, don't make conditions seem worse than they really are. Report your patient's conditions accurately. Don't make the patient sound sicker or healthier than they really are. Some providers have admitted to falsifying records to justify treatments or tests with managed care organizations just to stay in network. Document missed appointments. If a patient has missed an appointment, or if you do healthcare classes and they haven't attended, or they're just not following your home care instructions, write it down. That's a very important risk management recommendation, prevention, malpractice prevention. If you didn't write it down, it didn't happen. You've probably heard this before. In today's healthcare environment, it has more relevance before. Malpractice insurance carriers, Medicare, managed care organizations have all increased their demands for extensive and thorough clinical documentation. Your patient documentation must accurately reflect your clinical thought processes. Uncommon abbreviations. Okay, so for those of you that are still handwriting your notes, that's fine. You can still handwrite your notes, even next year, even 2 years from now. Aetna, Cigna, United Healthcare, personal injury, none of these carriers are requiring that you go to an EHR. You do not have to use an electronic health record if you don't want to. The only exception is Medicare. If you don't use an EHR, a certified EHR, Medicare will deduct a small percentage, I think it's 1 or 2% of your payment. Other than that, I don't know of any other carrier that will deduct payments if you don't use electronic health records. I have some clients, they make their handwritten notes. They don't want to switch, or maybe they don't want to use an electronic health record. Maybe they can't afford a documentation software. You could still use handwritten notes. We're not comparing apples to apples. You know, everybody should be going to electronic health records eventually, but for those of you that don't want to, it's okay. So if you're using handwritten notes, don't use uncommon abbreviations. Abbreviations are a wonderful tool that can help save time in writing daily records. But if you make up your own, you'll need to send a legend, a key code every time. Use standard abbreviations. Document normal and abnormal findings. On a particular busy day, you may be tempted to record only abnormal findings in the record. This can be dangerous. Although abnormal findings are important to determine a diagnosis, negative or normal findings are equally important because they can help rule out serious conditions. For example, the fact that a patient had a straight leg raise, negative Bacteru, negative Valsalva, normal motor strength, normal sensation, normal reflexes, that rules out disc injury. Home care instructions. Be specific when giving patients instructions for home care. If your patient should use ice, tell them how much to use, how long to use it, how to apply it. If you provide exercise instructions, be sure to include details such as the specific number of repetitions and sets to be performed. Provide exercise sheets and handouts. Have the patient sign and date the forms you give them. Give a copy to the patient. You keep the original. What about follow-up care? Always document when a patient should return for follow-up care. If a patient is told to call the office when care is needed, be sure to indicate that in the records. When no date for follow-up care is noted in your records, the attorney could allege this is evidence of abandonment. I know that sounds crazy, but it does happen. If the patient is being discharged, be sure to document that in the records too. So here's an example of a SOAP note. In my opinion, this is a perfect SOAP note. It could comply with Medicare, regular insurance, cash. It could work across the board. So this goes through the subjective. There's a little comment there on ADLs, objective findings to include the staples. In my opinion, the three staples are tenderness, spasm, and subluxations, which would meet the Medicare part exam requirement. A very good assessment on the objective findings there. Plan for treatment to include the specific bones that are being adjusted, how many minutes, exactly how many minutes you're performing any of the time-based codes and the muscles that they're being done on, patient improving as expected, patient to continue present treatment plan of 2 times a week, patient is scheduled for her next reevaluation on, put a date in there, patient tolerated the treatment well, the treatment was without incident. Every SOAP note should have the patient's name and date, your office name, address, phone number. Make sure you sign it. By the way, those of you listening to this presentation, if you would like a copy of this SOAP note, email amy@targetcoding.com and she'll get it to you. Let's go to step 4, CPT Diagnosis Code linking and pointing. So you see here at the top we have box 21 that has 4 diagnosis codes. And now we are performing certain procedures. So my recommendation is you point to the diagnosis codes that you're performing the procedure on. So on the right side you see the 98940. That's going to diagnosis codes 1 and 2 to the neck. 97140 to the lower back. That's a 722.52. And 98943 is pointing to the shoulder pain, 719.41. Some insurance companies require you to use the 5-1 modifier on the extremity adjustment. If you are getting paid without the 5-1, don't start using it. Come on, we need to be logical here. Now here's a little bit more of a complicated situation where we have 3-region adjustment and manual therapy. So the 3-region adjustment is on the neck, thoracic, and the sacroiliac joint, the pelvis. The manual therapy is just on the lower back. The cold pack is just on the lower back. The electrical stim, there are 2 codes for electrical stim. You see them on your screen. That's going to the neck and the lower back. And the therapeutic exercise is just on the neck. So that's how you diagnosis point. I recommend you try to do it. Now you see on the left side, I put, that's okay. The right side is much better. See, many software, if you put 4 diagnosis codes in box 21, it's automatically going to default to 1, 2, 3, 4 in box 24E. I don't like it, but if that's what's happening and you're getting paid, that's fine because you need to tell the story in the notes. The claim is one part of the story. The documentation is really the key way to prove what you're doing was necessary and justified. And then here's another way to start figuring out what are the high-value diagnosis codes. So a patient comes in, we see 9 diagnosis codes here on the left. Think of it like you're fielding a team. You have to field 4 players, but you got 9 players on your team, but you could only put 4 on the field. You want to pick your best 4 because you want to win the game. Pick the best 4 diagnosis codes, the ones that have the highest value, the ones that pay the most. If you're interested in learning more about which codes pay the most, visit targetcoding.com or Discount Medical Supplies and you'll see the book on the best CPT codes and diagnosis codes to maximize reimbursement. 12 visits later, you reevaluate the patient. Now you're down to 5 diagnosis codes. You went from 9 codes to 5 codes. What does that mean? That means 4 items got better. You helped the patient. They don't have those problems anymore. That's medical necessity when things get better. Whatever you did worked. And then here's a form that I recommend all my clients use. You could either enter this into your software or you can make copies of these sheets. This is in one of the books that I've written on the best diagnosis codes to maximize reimbursement. If you buy the book, I can email you this page. It's page 31 of the book, and you can have it in Microsoft Word and modify it for your practice. And after every exam and re-exam, you put the patient's name and date on, and you just check away, and then your staff members will know which diagnosis codes to put in order to maximize reimbursement. All right, we're up to step 5, which are cash plans and financial policies. So let me ask you a question. You ever think about how much it costs you to give a patient a treatment? Let's say your overhead is $10,000. That's everything, your rent, staff, all your leases on equipment, everything that it costs you to run your business costs $10,000, and you see 100 visits a month. That's 400. I'm sorry, 100 visits per week is 400 per month. 10,000 divided by 400 visits means it costs you $25 for each visit. It costs you, yes, it costs you money to give a patient a treatment. It costs you $25. So if you have cash patients coming in and they're paying you $20 each visit, you're losing $5 per visit. Now, I know there are some exceptions. There were some patients that I treated for free. They had a bona fide financial hardship. There are some patients I bartered with, but those were very rare instances. So make sure you run these numbers. You know, when you go to chiropractic college, you're not really taught about the business of chiropractic. You know, when people go to business school, like the Wharton Business School, they don't teach them how to become chiropractors there. When we go to chiropractic college, we're not taught how to be business people, but we need to. There are so many doctors I know that are spending 45 minutes to an hour with a patient, and they're collecting $80. I know many physical therapists spending an hour with a patient, collecting $60, $70. Not going to be able to make it in practice collecting such a small amount. At least most doctors will not be able, and physical therapists cannot run a business only collecting $60, $70, $80 for an hour worth of service. So let me ask you a question. Is one fee across the board really possible? Is it possible to have every man, woman, and child come into your office and pay you the same fee? I don't think so. Because you have many different situations. You have your normal, regular, standard fees. Let's say you would like to collect $50 per visit. That would be your normal fee. Don't use that fee. I'm not telling you to charge $50. This is just for educational purposes. Say your normal standard fee for a chiropractic adjustment is $50. Now you go in network with Blue Cross Blue Shield, Optum Health, American Specialty Health, Aetna, Cigna, United Healthcare, and they say, well, we're going to pay you $30. Well, my normal fee is $50. Well, sorry, we're going to pay you $30. Well, you have to write off $20. You don't have a choice. Next, you are a Medicare provider. Your normal fee is $50. Medicare says, we're going to pay you $25. Well, you don't have a choice. You can't collect the difference from the patient, so you have to write off half of that. You have to write off $25. Then we have work comp fees. Personal injury fees in most states are beautiful. Those pay very well. Then we have time of service administrative discount fees. We have financial hardship fees. And then we have DMPO, discount medical plan organization fees. So we have all these fees across the board. Many of you are in this situation where you have a little bit of all of these. You have regular cash patients coming in, then you have managed care. You're in network with these plans. You have Medicare patients coming in, workers' comp, personal injury. You have all these different fees. Does that mean you have a dual fee schedule? No, it doesn't. What it is, well, you should be telling your patients, your staff, if any state board investigated your practice, malpractice insurance company, insurance investigator investigated you, what you need to do is say this: I have one fee for my practice. One fee for my practice. And the only time I provide a discount is when I have to, when I'm required to do, because of a contractual legal document, a contractual network agreement, or because of the patient financial hardship. Again, even though you could be all across the board here on this screen, you should still be saying that you have one fee for your practice. And the only time you provide a discount is when you have to, when you're required to do so because of a contractual network agreement or because of a patient's financial hardship. Also, you should tell all your patients, especially your cash patients, that you're giving a little bit of a discount, what your normal fees are. Some providers only give discounts to cash patients, and they don't let them know the normal fees. See, this can cause confusion, sticker shock, and have a patient be really upset with you. Because you could have a cash patient come in and you're charging them X number of dollars, your cash fee, which is a lower fee. You don't tell them what your normal fee is, and now this patient gets into a car accident or they get insurance, and now you're charging your regular fee. So let's say you're charging the patient $30 as a cash patient. Don't use that fee. And now they're in a car accident, and now you're charging $150, or they get regular health insurance and you're charging that insurance company $150. This patient could say, what's going on? When I was coming in, I was a cash patient. I was only paying you $30. Now because I have insurance, you're charging $150. They could report you to the board. You could have problems. So make sure you tell your patients your normal fee when they're paying you cash. Next, let's say you want to charge your personal injury and regular insurance patients insurance $150 per visit. Don't use that fee, but let's say you want to charge $150 for your personal injury patients. And now you have a cash patient come in. You want to do the same thing and only charge $30. You can do that if you join a discount medical plan organization. The one I like best is Chiro Health USA. Chiro Health USA, contact them. Let them know you are interested in doing this. It could help discount your fees legally. It could prevent dual fee schedules. It works with cash patients and underinsured patients. It could even work with Medicare patients and patients with high deductibles. Set them up on Chiro Health USA and then set them up on an auto debit. To me, that's the best way to get this thing going. So make sure you have financial consultations with every patient. Who should do the financial consultation, the doctor or the staff? You know who should do it? Whoever's better at it. When I first started practicing, I hired staff. They didn't have any chiropractic experience, so I did the financial consultations. I was good at it. I got patients to pay. Then I hired a staff member, Tara. She was my best CA I ever had. She was better at getting patients to pay than I was, so she did the financial consultations. That was great. I was able to take a step back and just talk to the patients about their spine and their health, and I didn't talk to them about money. Well, Tara got pregnant and she left, hired a new CA. This new CA was not as good as Tara, was not as good as me as talking to patients about money. So I went back and started doing the financial consultations again. You know, what do you have to do in practice? You got to do whatever you got to do to make your practice successful. So if the doctor needs to talk to patients about money, the doctor should do it. If doesn't feel comfortable doing it and you give it to a CA who's not doing a good job, that leads to practice confusion, leads to practice upsets. So whoever's better at doing the financial consultation should do it. It's usually on the second visit. It gets patients to understand your office insurance billing and collections procedure. When you have a written policy that you give to the patient about finances, it gets patients to understand that collecting money from insurance company is not that easy. It educates the patients about acute care, chronic care, and wellness care. It gets patients to understand that they are responsible for a portion of the bill. It enhances communications with patients, and it prevents doctor-patient upsets. So just a few closing comments. I want to tell you a little bit about Target Coding's Smart Choice program. Our Smart Choice program will help you SWAN. Do you know what SWAN means? I'll tell you in a minute. First of all, about prevention. You know, just like most chiropractors would love to treat patients for prevention. If I had 50 patients coming in a day, I'd love all 50 patients to be coming in because it's their once-a-month checkup. It's nice. It's simple. You don't have to educate the patients. You don't have to worry about pain and discomfort. Lie down. Let me give you a tune-up next. Lie down. Let me give you a quick tune-up next. It's a beautiful way to practice, but it's not that easy. I was striving to make 80% of my practice maintenance, 20% acute care, but it was usually the opposite. So we're into prevention, just like you are into preventing problems with your patients. You should be into preventing audits. You should be into preventing problems in your practice. That's what our Smart Choice program does. It prevents problems. So if you're smart, you know how to prevent fraud and audits. If you're smart, you know how to strategically build Blue Cross Blue Shield, Aetna, Cigna, United Healthcare. Here's something I see all the time. Doctors are building units of a particular code. Let's say it's a time-based code, and they're only getting paid for one, even though they're billing for two. They're only getting paid for one, and they're in network with the plan. They're not getting paid for the second one. So you better charge the patient for the second one, or don't do it. If you don't strategically know how to bill and code, you're going to be spending a lot of time on not maximizing reimbursement. You should be collecting cash for many products and services. I don't recommend you have all your eggs in one basket. If you're smart, you're not underbilling. Some doctors are so afraid of audits that they're underbilling. If you're smart, you know how to code to the highest level of specificity. You know how to prevent dual fee schedules. We went over that already. If you're smart, you have trained staff members to help you maximize revenue. If you're smart, you know when not to use modifiers 52 and 59. Using those incorrectly will initiate an audit. I've seen it recently, a few times. If you're smart, you know how to build time codes properly. If you're smart, you'll consider our Smart Choice program. It will help you swan. That means sleep well at night. So contact us for more information. Now, you must check with all the carriers you bill prior to submitting claims based on the information provided in this presentation to ensure that it is compliant. Target coding and discount medical supplies does not guarantee that the information provided in this presentation will guarantee payment from any insurance carrier or patient. Target coding and discount medical supplies is not responsible for any insurance carrier or managed care organization laws, rules, and guidelines that may change following this presentation. Remember, things change all the time, so it's important for you to stay on top of any changes by attending seminars, webinars like these, and joining your national and state professional associations.
Thank you, Dr. Kotlar, for today's webinar. If anyone has any question, please feel free to type them in the question pane on the right-hand side. Well, apparently no one has any questions for today, Mr. Kotlar. Thanks for the presentation. Please remember to follow us in all our social networks, Facebook, Twitter, Google+, and as well, remember to visit our website for all your medical needs, discountmedicalsupplies.com. Have a nice day.